Sir, I think we should ask Dr. Pankaj also to present. Then we can,
Okay.
because
Okay.
this will be very common, this question. Yes.
Yes.
Dr.
Yes.
Pankaj,
Yeah. TD, please introduce Pankaj.
hello.
Yes, sir.
Pankaj.
Good evening, sir.
So, this second speaker is Dr. Pankaj, very bright young radiologist from PGI Chandigarh, and we depend a lot on him, especially for gallbladder cancer and many other problems. And he is one of the most busy persons as a radiologist in our institute. I think he once he present, then we can ask questions to Pankaj and Saurabh both. Pankaj, please go ahead. Thank you.
And I must add that Pankaj is the prime motivator of the GB RADs, like BIRADs and LIRADs. He
Yes, sir.
started GB RADs, and which he has published, and now it is being validated by several other groups, which is a very important ultrasound kind of guideline to differentiate between benign and malignant lesions of the gallbladder. Pankaj, please.
Good evening, everyone. I hope my screen is visible and I am well audible.
Screen nahi hai, Dr. Pankaj, screen is not visible. So
Okay.
please share.
I will share. Good evening, everyone. Thank you, Professor Kapoor and Professor Yadav, for that introduction. And I think I have a lot of motivation from both the moderators. I look forward to them for all kind of clinical inputs and guidances. Today, I'll be talking about imaging in abdominal tuberculosis. Introduction part has been mostly covered, and we know the gravity of the situation. And in fact, tuberculosis remains one of the most common diseases in our country. Though pulmonary tuberculosis is most common, we see a fair bit of extrapulmonary TB, of which abdominal involvement occurs in around 11 to 12% of patients. And imaging is cornerstone of diagnosis of abdominal tuberculosis. It has also been delved by the previous speakers that abdominal TB can involve the lymph nodes, peritoneum, intestinal tract, and solid viscera. A combination of intestinal, peritoneal, and lymphatic involvement is noted in 2/3 of the cases, and in another 1/3 there could be only extra-intestinal involvement. Coming to the various imaging modalities, we have a host of investigations that are available to us, of which plain radiographs are the basic initial investigation we rely on. Barium series, including the barium meal and barium meal follow-through, was considered a very important imaging component for evaluating patients with suspected GI tuberculosis, but it has mostly been replaced by CT-based studies, including CT enterography. I will be talking about that later. Ultrasound, CT, and MRI play a very important role to evaluate the entire extent of disease, particularly in case of GI tract. It provides a detailed information of the lumen, the wall, as well as extraluminal components, as well as other parts of the abdominal cavity. There is some evolving data regarding the role of PET CT in patients with abdominal tuberculosis. Abdominal radiograph mostly plays a role when we see a patient coming with features of small bowel obstruction. This is just for the residents a bit of recap of how we diagnose intestinal obstruction on a plain radiograph. So a plain radiograph in case of intestinal obstruction will show us dilated gas-filled bowel loops. Please mind that when these loops are filled with fluid, which is not an uncommon scenario, we will see a gasless abdomen. In the absence of Ryle's tube, dilated stomach along with dilated small bowel also points to the presence of small bowel obstruction. And when small bowel is dilated out of proportion to the colon, that's another sign of small bowel obstruction. In addition, when we obtain radiographs in erect or lateral position, the presence of air fluid levels that are multiple and at different levels, longer than 2.5 centimeters, also suggest the possibility of intestinal obstruction on plain radiograph. Plain radiographs are also important to evaluate the presence of chest disease in patients in whom we are strongly suspecting abdominal TB, and also to look for any features of intestinal perforation in the form of air under diaphragm. Ultrasound, I would say, is an underutilized tool in patients with abdominal tuberculosis. We have started increasingly utilize it for evaluation of bowel in abdominal TB as well as other diseases. It is as sensitive as abdominal radiograph, but is more specific than abdominal radiograph for the diagnosis of intestinal tuberculosis. Particularly, the IC region is very well visualized on ultrasound, and with expertise, one would be really utilizing it to its maximum potential. It can give us the cause and level of obstruction, and can also help us diagnose some of the complications of intestinal tuberculosis. Needless to say, ultrasound is a very useful tool for evaluation of lymph nodes as well as solid viscera, and it provides guidance for fine needle aspiration cytology or biopsy that is frequently employed in diagnosis of abdominal tuberculosis. Abdominal CT is cornerstone of imaging of patients with suspected abdominal tuberculosis, and there are different techniques of the CT that we employ for patients suspected to suffer from abdominal tuberculosis. We can perform CT with oral contrast. IV contrast is always mandatory. In patients who present with acute obstruction, usually nothing is given orally, as we know that bowel is already dilated and fluid filled. I'll be talking about CT angiography, which is being increasingly utilized and is replacing barium follow-up in patients with abdominal TB. And we see that abdominal CT has a very high sensitivity and specificity for diagnosis of small bowel obstruction in general, and also in the setting of abdominal tuberculosis. Now, the question is why we have moved away from barium meal follow-through into CT angiography is because of several advantages of a cross-sectional imaging technique and several disadvantages with barium meal follow-through. BMFT, as we know, is operator dependent and involves lengthy examinations. Bowel loops, as we know, are overlapping structures, and hence in two-dimensional imaging, it will be difficult to discern the changes or lesions in all the bowel loops. And the IC junction is very difficult to demonstrate on a barium meal follow-through. And obviously, as I've discussed previously, CT gives us a comprehensive evaluation of the wall as well as extraintestinal abnormalities. The other important thing for the students is what is CT enteroglysis, which is and how does it differ from CT enterography. So we should remember that CT enterography is now the standard technique, and we use CT enteroglysis very sparingly, at least in our centers, and I am aware of the other centers in India also, that most of the centers use CT enterography. CT enteroglysis basically involves intubation of the duodenum under fluoroscopy, and hence it increases the radiation dose as well as discomfort to the patient. And some of the studies have shown that the distension achieved with CT enterography is comparable to that achieved with CT enteroglysis. We also have MR enterography at our disposal, and the advantages are the lack of ionizing radiation, and a very, very useful advantage of MR enterography is the ability to perform a dynamic imaging, which can help us differentiate a stricture from basically a peristaltic motion, which will be, difficult on any other imaging test. However, we know that MR enterography has a limited availability as well as limited expertise is available for evaluation of MR examinations. So I'll be just showing few of the techniques here. So this was a CT of the abdomen done with positive oral contrast. As you can see, there is presence of positive contrast within the bowel. Compare this with this particular type of examination, which is performed with the neutral oral contrast, which is typically a PEG or mannitol. We use PEG in our institution, and other institutions use mannitol, so they can be used interchangeably. These are some of the images of MR enterography. So this is these are T2 weighted sequences where we can see that the fluid which is administered is appearing bright. However, the cornerstone of MR enterography is a dynamic contrast enhanced MR, where we see the fluid as a black structure, and any lesion will be appearing as a bright structure against that black background. We theoretically can understand that PET will add the functional component to the CT enterography component. So there is something known as PET CT enterography. However, we also understand that it increases the cost significantly as well as radiation dose. So it's not very commonly employed and is mostly used as a research tool or in various research protocols. In some cases where there is a diagnostic dilemma which remains unresolved after extensive evaluation, PET CT enterography may be utilized. Coming to the description of imaging findings in each particular type of abdominal TB. Abdominal lymphadenopathy is one of the commonest manifestations of abdominal tuberculosis, and usually multiple lymph nodes are affected, and mesenteric and peripancreatic group of lymph nodes are the most commonly involved. The hallmark of tubercular lymphadenitis is the presence of necrotic lymph nodes that appear as hypoechoic or anechoic on ultrasound. However, one should remember that this classic pattern is present only in around half of the patients with abdominal TB. Now, this is one of the older slides. I just intentionally put it to demonstrate that how necrotic lymph nodes appear. So, necrotic lymph nodes appear as peripherally enhancing structures with central necrosis appearing as a black thing within the center of the lymph node. So the presence of necrotic lymph nodes is in fact one of the most specific features of abdominal tuberculosis when we are trying to differentiate it from other common mimickers. The other patterns of tubercular lymph nodes could be a conglomerate lymph node mass in the mesentery or elsewhere. And sometimes what we have seen is that patients may have increased number of lymph nodes which are of normal size within the mesentery. Besides necrosis, calcification also supports the diagnosis of tuberculosis, or in general, I would say granulomatous inflammation, and it does give us a reasonable idea as to what we are dealing with. Also, it is important to remember that tubercular lymphadenitis must be differentiated from lymphoma, and I have just tabulated some of the differences between the two. So here we can see that there are necrotic, peripherally enhancing lymph nodes. Compare this with lymphoma, where the lymph nodes appear more homogeneous. Also, note the location of lymph nodes. Lymph nodes in TB are usually the most concentrated in the mesentery. And in case of lymphoma, these are present both in the upper as well as lower abdomen. Retrocrural location is one of the sites which favors the lymphomatous involvement. Now, coming to peritoneal tuberculosis, previous speaker has shed some light on this particular topic, but what I would like to add here is the fact that this classification into wet, fibrotic, and dry type is somewhat confusing, and we do see overlapping features. And our medical and gastroenterology group has sort of tried to propose a clinical-based classification, which is basically a distension dominant type of peritoneal tuberculosis versus a pain obstruction dominant type of tuberculosis, which are characterized respectively by presence of ascites or presence of cocoon and peritoneal adhesions or fibrosis. Coming to some of the examples of peritoneal tuberculosis. So one of the most common findings in peritoneal tuberculosis is presence of loculated ascites. On ultrasound, it is not uncommon to find echoes within the peritoneal fluid on ultrasound. And on CT, we see that there is enhancement of the peritoneum, and usually the fluid in case of abdominal tuberculosis appears hyperdense as compared to, maybe you can compare it with urinary bladder. So urine will be a baseline for comparison. And if we see a fluid more dense than that, then we can suspect the presence of tubercular peritonitis. These are some of the examples to show the omental involvement. So these are ultrasound images. So we use ultrasound very frequently in evaluating patients with abdominal TB, and we are now able to identify the presence of omental thickening on ultrasound using a linear high resolution probe. So you can see that there is a plaque-like thickening of the omentum here. Another example again to show the thickening of the omentum along with ascites. Another example, you can see that the omentum is thickened and heterogeneous. On CT, we again see omentum as either smudge structure in the form of nodules. You can see nodules here, multiple nodules. And I'll be discussing some differences between peritoneal tuberculosis and peritoneal carcinomatosis later. Again, the mesentery is also involved in case of peritoneal tuberculosis, and there can be presence of lymph nodes or micronodules along with presence of ascites and peritoneal thickening. This entity has been discussed previously by both the speakers. Again, imaging is diagnostic of this disease. And again, we can see that there is clumping of the bowel loops, and one can see that there is an enhancing membrane leading to the obstruction. This is a rare presentation, one of the odd cases that I saw, where we can see that there is formation of collection in the peritoneal cavity, CT of the same patient, and we were keeping possibilities of some soft tissue tumors. When we sort of biopsied this case, it turned out to be tubercular abscess in the peritoneal cavity. As I discussed previously, one of the important differentials of peritoneal tuberculosis is peritoneal carcinomatosis. Again, similar findings: presence of omental caking, large amount of ascites. Again, the presence of omental nodules, some degree of peritoneal thickening, and neck cell lesions. So, I mean, both findings, as you can see in TB and peritoneal carcinomatosis, can overlap. So, are there any features that can help us differentiate between the two? This was a recent study performed by our group, where actually we saw that except for the nodular involvement of the omentum, there were no other features in the mesentery or peritoneum or omentum that could differentiate peritoneal tuberculosis from peritoneal carcinomatosis. However, the presence of loculated ascites, conglomerated lymph nodes, and the mesenteric location of lymph nodes were significantly associated with tubercular peritonitis. Coming to the imaging of GI tract, as previous speakers have told, any part of the GI tract can be involved, though the ileocecal region is the most commonly involved site. Esophageal TB is uncommon, and we recently performed a systematic review and found that I'm talking just of the imaging findings here, but this was obviously a comprehensive systematic review covering other features also. And we found that the most common finding in case of chest X-ray was basically mediastinal finding. And I mean, it is logical also that most of the findings of esophageal tuberculosis will be because of the lymph node compression. And on barium swallow, one can expect presence of extrinsic compression of the esophagus, sinus formation, strictures or fistula formation. These are images from Professor Nagi's paper published in Acta Radiologica in 2003. And we know that Madam was expert in performing these barium studies. And on CT chest, again, we can expect mediastinal lymphadenopathy and non-specific esophageal wall thickening. Gastroenterology TB, again, the previous speakers have highlighted its rarity and non-specific clinical features. And imaging manifestations basically, again, are because of either the extrinsic compression by a lymph node or mural involvement leading on to stricture. Another example of the entropyloric stricture in the setting of the gastroduodenal tuberculosis. This was an interesting case. Here, the coronal CT shows us that there is asymmetric mural thickening of the duodenum with marked luminal narrowing. What led us to the diagnosis of TB was this necrotic mesenteric lymph node and some necrotic lymph nodes in the mediastinum. So this was a case of duodenal tuberculosis. Coming to the tubercular enteritis, this classification, I'm not sure whether it is followed now, but this was conventionally sort of stated as first stage, where there was accelerated transition in the intestine, followed by a stage of ulceration, and finally the formation of strictures. Now, these were very important signs previously. I don't think these are, seen in the present scenario where barium follow-through is not performed. But for students historically, we had signs because of the changes in morphology of the cecum as well as IC valve, leading on to different imaging appearances of the barium meal study. So here we can see that the cecum is markedly contracted and there is widening of the IC valve. Here we have a stricture and ulceration of the IC valve. The hallmark of imaging diagnosis is now the ability to identify the mural changes directly as well as extra luminal changes on CT. And the finding which we rely on diagnosis of TB is basically presence of mural thickening present mostly in the terminal ileum, IC valve, and cecum in a contiguous fashion. Initially, the thickening could be mild, but later on there could be marked thickening of the bowel. There could be adherence with the adjacent loops, and together with presence of multiple lymph nodes around it. Some of the important features of abdominal tuberculosis is presence of short strictures, which can be multiple or solitary, and usually associated with stricture in the ileocecal region. And symmetric involvement is more common. I'll be talking more about these when I talk about differences between TB and Crohn's disease. Now, this is a case where we perform both CT as well as the barium enteroclysis. So here we can see how actually CT adds to our diagnosis. In barium enteroclysis, as we can see that we can just see the lumen, and there is a very short stricture, very tight stricture in the ileum. However, on CT we see that there is presence of mural thickening, which is circumferential and concentric. It is homogeneous. We don't really see any increased mesenteric vascularity. So this was basically a case of intestinal tuberculosis. So as you can make out, this was a study that was done with oral positive oral contrast. However, we are performing more of enteroclysis studies now, and here are some of the other manifestations of intestinal tuberculosis. So you can see that there is a symmetric mural thickening of the terminal ileum. Again, there is no increased vascularity. There is no mural stratification. On the other hand, this was a case of intestinal tuberculosis where you can see mural stratification. So by mural stratification, I mean that there is more enhancement of the inner layer compared to rest of the wall of the intestine, and also see that there is a homogeneously enhancing lymph node. Now, this could be really a great confusion between Crohn's disease and TB, but this was a case of proven, histopathologically proven case of TB. Another example of tubercular stricture, and in this case, a rather unusual manifestation of a long segment stricture of the tubercular enteritis. This is more common finding which we can correlate from a barium meal follow-through study, extremely contracted conical type of cecum, and there is a stricture at the IC valve, and you can see a large enterolith sitting at the terminal ileum. We really don't use much of MR enterography. These were some of the cases we performed mostly because there was concern of repeated radiation exposure. So in this case, again, you can see that there is a circumferential mural thickening of the terminal ileum, beautifully seen at contrast enhanced MR enterography. This is a important topic, differentiation of ileocecal tuberculosis from Crohn's disease. At least the tertiary centers, we are commonly faced with this dilemma. And these are just, features that can guide us. Mind you that these are not absolute, and overlap is very common. But we know that cecum along with ileum, or contiguous involvement of cecum and ileum, is much more common in case of ileocecal TB. Tubercular strictures are short segment, usually not more than 4 segments are involved. Skip lesions are rare, and there are other features also. I would recommend the students to go through this paper. However, you must understand that these features may not be statistically significant. This was a systematic review performed by the AIMS group, which showed that the finding that had a highest diagnostic accuracy for diagnosis of ileocecal TB was necrotic lymph node. So in fact, this is the most specific finding. So if in a scenario where you are faced with dilemma between TB and Crohn's disease, you see necrotic lymph nodes, you are absolutely sure that you are dealing with tuberculosis and not Crohn's disease. For the diagnosis of Crohn's disease, home sign, which is basically increased mesenteric vascularity followed by skip lesions, is having the highest diagnostic accuracy. Colorectal TB, again, comprises around 10% of the GI TB, and based on different series, the commonest sites of involvement have been variably reported. This could be ascending colon or the transverse colon, and multiple sites of involvement are common. I'll show you some examples here. So this was a patient with mural thickening and enhancement involving the cecum. And usually it has been reported that cecal involvement, if we consider that as a sort of colonic TB, so it will be usually contiguous with the ileum. So in strict sense, it will still be ileocecal TB. But in this particular case, we are seeing that the thickening is extending to involve the ascending colon. Also see a lot of mesenteric and pericolonic necrotic lymph nodes. You can see this peripheral enhancement and central necrosis. This was a case where we see the thickening extending to the hepatic flexure, lot of thickening, and the differential diagnosis of colonic malignancy should definitely be considered in this case. A few more examples here: a very tight stricture of the hepatic flexure, In this case, you can see multiple strictures involving the descending colon as well as sigmoid colon. An annular type of stricture involving the ascending colon here. And in this case, what actually leads us to diagnosis is presence of extraintestinal manifestation in the form of a large SWAS abscess. A case of colonic TB diagnosed on MR enterography. So here we can see that there is a tight stricture of the ascending colon, which is showing a lot of neural enhancement. Again, I would again like to re-emphasize one fact is that in patients with suspected abdominal TB, sometimes the clue may not come from abdomen itself, but from the other side. So, for example, in this case, we see a lot of miliary nodules in the lungs, which can be one of the important findings for clinching the diagnosis. In this case, we can see that there is left-sided pleural effusion with calcification. And in this example, we see there is some pericardial effusion. So these could be some important ancillary findings. In this case, you can see that there is a SWAS, ileus abscess. So one should carefully look for these findings, and these can actually lead us to diagnosis. I'll be quickly running through some rare examples of abdominal TB. These have already been discussed by my previous colleagues, so I'll be focusing more on the imaging features here. So these are examples from our own patients. So in this case, we see micronodular form of hepatic TB. So we again rely a lot on ultrasound because ultrasound has a higher, I would say, resolution for picking up these subtle findings, particularly the high resolution probe. So you can see these ill-defined hypoechoic lesions, which are smaller than 10 mm. Another case where we see slightly larger nodules, case of macronodular TB more than 10 mm. And in this case, we saw a single lesion, which we also confirmed on CT with some peripheral HPRD. This was confirmed to be case of hepatic TB again. A very rare form of TB, which I would like the students to remember, is one where you see some lesion along the capsule, which is a serohepatic form of TB, which is also known as sugar coating. We often on see these type of cases, and now from our experience, we know that we are dealing with TB. So this form should be kept in mind. Splenic tuberculosis again presents in a similar way with micro nodules. Again, these are very well seen on a high resolution ultrasound compared to CT. And another example where we had just one lesion in the spleen, a case of macronodular TB. This was a case of splenic tubercular abscess, a large lesion in the inferior pole. This was a rather interesting case, a patient with acute pancreatitis in whom incidentally we detected a splenic lesion. We performed CUS and thought it was a case of hemangioma, but as patient was symptomatic, we performed an FNA and a diagnosis of acid-fast bacilli positive TB was confirmed. Biliary tract involvement is rare. I don't have examples to show here, but I would like to, point here that features that should lead us to think about biliary TB or tubercular cholangitis is the presence of associated findings of hepatic granulomas or calcified necrotic locoregional lymph nodes and periductal calcification. Pancreatic TB again is rare. The previous speakers have shown some examples. I'll be adding to it. So as has been told previously, most commonly the head of the pancreas is involved. And in fact, some of the investigators try to club the peripancreatic lymph nodes together with pancreas to call it pancreatic TB. It is a bit, debatable. But in this particular example, we see that there are multiple lesions in the body and tail of pancreas and confirmed to be a case of pancreatic TB. Appendicular involvement is very rare, but I would like to, highlight here, particularly because of the fact that sometimes if one sees a disproportionate thickening of the cecum and ascending colon in a patient suspected to be a case of idiopathic acute appendicitis, it is very important to consider a diagnosis of TB. And if these patients undergo appendectomy without suspecting a diagnosis of abdominal TB, then there could be real problems like sinus formation. And we have seen a recent case in our center where a young lady had features of acute appendicitis, but imaging showed a lot of thickening of the cecum and ascending colon. In fact, the surgeon has also recorded that there was a very significant thickening of the cecum and terminal ileum, but underwent appendectomy, but later on developed sinus and was finally confirmed as a case of appendicular TB, or rather, I would say the colonic TB. So to summarize, imaging is vital in managing patients with abdominal TB. Contrast enhanced CT is the most common imaging test. CT enterography allows a comprehensive evaluation of bowel and dysentery. We should use MR enterography when we are performing multiple examinations. We should always keep radiation dose in mind. And personally, I believe that ultrasound is far underutilized. And I would like to compare it with Crohn's disease. Now, you see, European countries are using ultrasound very frequently in patients with Crohn's disease. So we should also think about incorporating more of ultrasound in evaluation of patients with abdominal tuberculosis. Thank you very much.
So, thank you, Dr. Pankaj. You shared such a nice pictures and especially to differentiate between the other diseases of the abdomen, where tuberculosis, how can it can be differentiated from malignancy. So, I would like to start with asking one simple question that rarely we have seen internal fistula also between the bowel, maybe small bowel with large bowel, and one of the patient had the fistula with the bladder. So, any experience of this type of tuberculosis?
Yeah, thank you for asking that question, sir. In fact, I mean, sinuses and fistulas are considered to be much more common with Crohn's disease, but I agree with you that there are some cases on and off that we see there is some localized or contained perforation, and that later converts to formation of enteroenteric fistula. So, if patient has other features that are sort of going along with abdominal TB, even in the presence of enteroenteric fistula, one has to consider diagnosis of abdominal TB rather than Crohn's disease, although enteroenteric fistulas are more common in Crohn's disease.
And one more point, you in nodal, you talked about necrosis. That would happen even in malignancy, nodal necrosis. So one differentiation you told that it would be in the mesentery, more in the mesenteric area, and malignancy part maybe more in the along the vessels. Any other differentiating features radiological other than site?
Yeah, sir. I mean, that's again a difficult clinical scenario. I think we get a lot of input from the patient's clinical presentation or from our, clinical colleagues. But usually, if, my personal experience is that we see a patient who is young and who has necrotic lymph nodes, our tendency is more towards thinking it to be a case of abdominal TB. On the other hand, in a patient who is elderly, with necrotic lymph nodes more in retroperitoneal location, bulkier in size, we would think more on lines of malignancy. But in these cases, we, as was highlighted by one of the speakers, we definitely want to perform a biopsy, core biopsy or FNA sometimes. If we are suspecting more on lines of malignancy, I personally prefer to perform biopsy rather than performing FNA alone. But yes, it can be sometimes a very, very difficult scenario to differentiate the two.
So I think most of the things have been covered with the very strong message that if you want to label somebody like malignancy and want to either exclude the diagnosis of malignancy or try to be confirmed about the diagnosis of abdominal tuberculosis, so ultimately we have to take the help of any type of tissue diagnosis. Any other comment, Kapoor sir? Then
Yeah,
we can.
I have two questions, Pankaj. One is that is there today any place and role of simple contrast studies like barium or gastrographin?
Yes, sir, we are performing barium swallows even today. But as far as the small bowel barium studies are concerned, we have totally stopped doing that. And it's just the post-op scenario where we are doing some barium or contrast studies. And the reason is quite clear that we get much more information with CT than what we get with barium.
The other is that between CT and MR, because many of these patients are young women, can MR give the same information as CT? Because then you can do it safely without risk of radiation.
Yeah, sir, my personal experience and recommendation is to basically do at least CT at baseline. So because CT sections are much more thinner and we have much more confidence when we are scrolling through the entire scan. So I think the baseline scan should be a CT scan. I think there may be differences of opinion, I agree, but I mean, my personal preference would be to do a baseline CT, and on follow-up, definitely we know where is the disease, and following that up would be easier based on MR.
The other is many surgical students are not clear as to what is the difference between enterography and enteroclysis.
Okay, I try to highlight that a bit, but I'll again sort of clarify it. So when we are saying enteroclysis, basically we are trying to intubate, putting a tube through the nasal route into the, I mean, at least across the pylorus into the duodenum, or preferably into the first part of the duodenum, and then we are trying to instill the contrast, whatever contrast we want to give. Usually we are giving a neutral contrast, which is either a PEG or a mannitol, and we have definite protocols for that. I will not go into that the detail of that, but basically putting a tube and giving much more in a controlled way is basically what we call as enteroclysis. On the other hand, when we say CT enterography, we are giving orally, we are allowing the patient to take orally, but again, one has to keep in mind that it is not like the routine CT with oral contrast, because here we have specific instruction for the patient. We want patient to divide the oral fluid into definite aliquots. By that I mean that if we have to give 1.5 liter to the patient, we advise the patient to divide that into 4 or 5 halves, and then he has to take those halves, I mean, over certain time interval, rather than taking it continuously, because we want to have a predictable distension of the entire bowel. So that's the difference.
My colleague, Dr. Sanjay Gambhir, who's Chief of Nuclear Medicine at SGPGI, he wants to make a comment. Gambhir, please come in.
Yeah. Thank you, Dr. Kapoor. Very nice presentations, all which were just enumerated. A very interesting discussion. So I would like to add about the PET in specific. So though it was just mentioned that it can be done in the PET enteroclysis, so I would like to enumerate a few more things about PET. We have done studies specifically in extra, to extra chest tuberculosis outside the chest, especially the abdominal tuberculosis and anywhere else. So one thing we have found, and it was done under the aegis of IAEA, that is International Atomic Agency, and most of the studies were contributed by the Indian participants, including PGI Chandigarh. So what we found out briefly is, as PET does it from the head to toe or the mid-thigh, so you get all the lesions in tuberculosis. Tuberculosis or other granulomatous disease take up FDG very strongly, very actively. So as somebody earlier said, you do multiple ultrasound of each axilla and whatever. So all that is covered in one go. You see everything. So of course, the differential diagnosis issue remains, whether it's Crohn's or you're talking of the malignancy or your other granulomatous disease. So other thing is, by the distribution of these lesions, you know that it is, outside the abdomen too, or the pelvic regions are involved, like earlier mentioned by Dr. Kapoor, the gynecological cases, the reproductive organs. So by the distribution and multiplicity of the tissue outside the chest, you come to know from distribution pattern is likely to be tuberculosis. The other thing is, the cases we did was which were screened with X-ray chest or CT or even ultrasound, and there was no pointing lesion. So that was our core group. So what PET does is will give you the lesion even in the solid organs of the abdomen, like you were talking about spleen and the liver. So you know which is the lesion from where you can take the tissue or biopsy, which you are not able to find on the ultrasound and all. So overall holistic picture of the disease, burden of the disease, so to say, and likely point from where you can take the tissue and make the diagnosis. Still, at times when you take tissue, I know that molecular part has not yet been discussed, still you fail to establish tuberculosis from the tissue sample or the fluids from the loculated cavity or peritoneal masses, whatever. So that distribution gives you a very high reference that it is likely to be tuberculosis, or you can take sample. And third thing, I think you will discuss tomorrow and all, is about the treatment, the length of the treatment, the burden of the disease, and when you stop, apart from the standard protocol, when do you stop your antitubercular treatment? As was mentioned, these are very toxic treatment, medicine, and some people do not bear it well. So when the lesion has completely gone away, the inflammation has gone away, and you can safely stop the treatment. And the ones where within first 3 months the response is not coming, picture is still positive, and these are likely to be the resistant variety. If matching with some resistance test is done right at the beginning of the treatment regimen or not, so some patients don't respond. So these are 2-3 points: multiplicity of the organ involvement, point from where to take the biopsy, and follow up the patient. We have found it to be very useful. And of course, PET also does a CT. So distribution of nodes, which are very active, along with their position or necrosis, everything is obtainable in one test. So these are my comments. Thank you.
Thank you. To highlight what Dr. Sanjay Gambhir said, I think very important point. I am just showing a picture. I hope you can see it. This is somebody known to me who had a young lady who had multiple lymph nodes all over the body. And the clinical diagnosis obviously was lymphoma because she had some systemic symptoms also. And a PET was done, which showed involvement of each and every group of lymph nodes, including lesion in the liver. And then, fortunately, the biopsy showed that this is tuberculosis. So she is now being treated with the ATT. So just to highlight what Dr. Gambhir said. And of course, the counter is that it can create problem by showing false negative lesion. So, it lights up like a malignancy in cases where we are thinking of malignancy, but it is not malignant.
Tissue has to be taken off for the final thing. Yeah, definitely.
Sir, I have one question, sir.
Yes,
to
go
Sanjay
ahead, please come in.
Sir, is there any cutoff value of FT uptake which differentiate between malignancy or tuberculosis, sir?
Sanjay, would you like to take that?
Yeah. So this is very oft asked question for malignancy or various kind of malignancy or sarcoma or whatever. So there are no cutoffs. So that point should be very, very clear, whether it's lymphoma or whether it's Crohn. Is the distribution and the follow-up, if you have the tissue or follow-up PET scans or whatever follow-up you are doing. So short answer is there are no cutoff. Usually the granuloma matrix uptake SUVs are much higher than again, there are overlaps. Usually, I'm saying usually. So there is no sharp cutoff. That's point. So people ask for it. I think more important is the way these lesions are, what our experience has told is the way these are distributed. And then you can even at times people are presented as the extra pulmonary, but we end up seeing the pulmonary involvement also, which was not picked up by the CT or the plain X-ray. So the distribution is very important. Burden of the disease, and you have to have tissue. Once you have got that, you still have doubts, you have to put get a biopsy or FNAC fluid, whatever you want to do. So no cutoffs.
Yes, sir. So my second question is, many of the patient who comes to us, they have already history of some carcinoma. So they go for their they go to the medical oncology part, and directly they will do the PET CT instead of CCT or some other investigations. So should we go for CT abdomen again after PET CT, or should we rely on the finding of PET CT, sir?
Yeah, so a very good question. You see, if you are doing PET CT studies, one should be clear. Normally, it can be like any CT, it can be done with the CT contrast or without the CT. Based on the indication, what we are looking for, whether the referring physician suggests or we think is appropriate, we add the contrast. We don't add it right and left. Lot of centers private in India, they as a routine protocol, they do all their PET CT studies with contrast, simply based on the premise that something should not be missed, right? So they want to do it.
Thank you, sir. Thank you very much, sir.
Just now, Dr. Kailash Kudia has sent me an article which they have published just today only, along with Dr. B.R. Mittal in nuclear medicine, where they have used PET CT for diagnosing lupus enteritis, which I don't have the details, but probably the clinical diagnosis was tuberculosis. So yeah,